Hello everyone, I am Dr. Saradha, Assistant Professor, Department of Periodontology, Vinayaga Missions, Shankaracharya Dental College. Today I am going to move on the topic acute gingival infections. Contents, it includes introduction, necrotizing ulcerative gingivitis, primary herpetic gingivostomatitis, pericoronitis, conclusion. Coming to the introduction. Acute gingival infections usually present with painful intraoral or perioral lesions. Usually these patients require immediate treatment to relieve the pain and also to resolve the infection. So, for these patients to determine these conditions and signs and symptoms are the most important for proper diagnosis and to execute the treatment plan. So, it is important for diagnosis based on the signs and symptoms. Coming to the necrotizing ulcerative gingivitis. The term it includes necrotizing. It's a necrosis, ulceration and inflammation of the gingiva. So, it can be probably due to pre-existing gingivitis which can be the predisposing factor for this lesion, and it is a microbial disease of the gingiva in case of impaired host response, and it can be characterized by death and sloughing of the gingival tissues and present with characteristics, signs and symptoms. And also other name also Vincent's disease, acute ulceromembranous gingivitis, trench mouth, ulcerative gingivitis and Vincent's stomatitis. History has been documented since 4th century. Greek soldiers were affected with sore mouth and foul smelling breath. In 1778, John Hunter described the clinical findings and differentiated the anuk from scurvy and chronic periodontitis, and it also occurred in epidemic form in the French army in the 19th century, and it is more common in malnourished children and young adults with HIV infection, and it is commonly found in improving or developing countries. In 1886, Hirsch et al., a German pathologist, discusses some of these features with such as enlarged lymph nodes, fever and malaise. In 1890, Plant and Vincent described the disease and attributed its origin to fusiform bacilli and spirochetes. And coming to the etiology, the role of bacteria. Plant in 1894 and Vincent in 1896, they have postulated that NUG was characterized by specific bacteria which includes fusiform species and spirochetes, and role of the bacteria is one of the reasons for NUG, and there are existing factors which can be described later in the etiology. So, role of host response. NUG was associated with physical and emotional stress and decreased in resistance to infection, that is immunocompromised patients. Local predisposing factors. Local predisposing factors such as pre-existing gingivitis which leads to the accumulation of plaque and debris and injury to the gingiva, smoking and deep periodontal pockets and pericoronal flaps. These are the reasons for predisposing factors which leads to NUG, whereas pericoronal flaps and deep periodontal pockets, these are the vulnerable areas where the plaque retention causes and it will lead to the NUG. And systemic predisposing factors such as nutritional deficiency, especially poor diet which will be the predisposing factor, and vitamin deficiencies such as B and C will lead to the NUG formation. Debilitating diseases such as syphilis, ulcer, gastrocolitis, leukemia, and these conditions will also lead to the NUG formation, and psychosomatic factors also will lead to the NUG. Clinical features. It is an acute disease. It undergoes diminution without treatment will leading to the subacute stage. With treatment also it will lead to subacute stage, and it also has a history of repeated remissions and exacerbations, and it also occurs in patients who are infected. So, there has a recurrent history. They also occur in patients who had dental treatment after 2 or 3 days after that, and it may involve single tooth, multiple tooth, or it may involve widespread throughout the mouth. It causes necrotizing ulcerative gingivitis whenever it involves deep into the tissues, causes tissue destruction leading to the necrotizing ulcerative periodontitis. If this bone loss happens, it is called necrotizing ulcerative periodontitis. Especially these necrotizing periodontitis occur in long standing diseases. That is that whenever it is not treated, it will lead to necrotizing ulcerative periodontitis or otherwise in patients with immunosuppression. Coming to the oral signs, the characteristic oral sign is punched out or crater like depression. Here the punched out or crater like depression we will see here is at the interdental papillae. Sometimes it may extends to the gingival margin and rarely to the attached gingiva and oral mucosa. Here the lesion will be covered by yellowish white or grayish white membrane called pseudomembrane. This pseudomembrane will differentiate from adjacent clear mucosa which is known as linear erythema. Whenever this pseudomembrane will be removed, the underlying erythematous gingiva will be exposed which will be hemorrhagic. And other signs includes fetid odor will be there. There will be an increased salivation. Here rather than periodontal pocket, recession can be seen because in periodontal pocket here the gingiva will become necrotic. In case of periodontal pocket, junctional epithelium will move down apically towards the root surface, whereas in case of nug there is a necrosis of the marginal gingiva which will lead to the recession. Here we can see these are the lesions which extends the marginal gingiva and interdental papilla. Here this we say you can see the interdental gingiva with a crater formation. Coming to the oral symptoms, these lesions are extremely sensitive to touch and there will be constant radiating and gnawing type of pain which will be intensified by eating on spicy foods or hot foods and difficult in mastication, and there will be metallic foul taste and patient will be having a pasty saliva. And coming to the extraoral signs and symptoms, there will be regional local lymphadenopathy will be present and also along with fever and increased pulse rate, leukocytosis, loss of appetite and general lassitude will be present in case of severe conditions. And systemic reactions are more severe in children. And insomnia, constipation and gastrointestinal disorders and headache and mental depression, these are also will be present in cases of severe conditions. And coming to the clinical course, Pinberg has described the staging of nug into this. Usually the lesion starts at the tip of the interdental papilla and will extends all over, then it will extends all over the papilla and then it involves the marginal gingiva. Here in this picture we can clearly see that there is an involvement of the entire papilla and marginal gingiva. And whenever it will involve marginal gingiva, sometimes it will extend to the attached gingiva and there which will leading to the necrosis of the bone. Please note that here the gingiva is not getting inflamed to resolve. Here the gingiva is become necrotic and dead. So which leads to the exposure of the bone. And another classification staging has been given by Horning and Cohen into stage 1, necrosis of the tip of the interdental papilla, and stage 2, necrosis of the tip entire papilla, stage 3, necrosis extending to the marginal gingiva, and stage 4, necrosis extending to the attached gingiva, and stage 5, necrosis extending to the buccal and labial mucosa, stage 6, necrosis exposing the alveolar bone, and stage 7 where here necrosis extending from alveolar bone to perforating the skin or cheek, which we call as noma. And histopathology. Histopathology is where that is the section of the tissue piece will be observed under microscope. Here in microscopically this necrotizing ulcerative periodontitis will be seen as a inflammation of the gingiva. Here histopathological section means both epithelium and connective tissue. Here the epithelium is a stratified squamous epithelium and the surface epithelium is destroyed and replaced by meshwork of fibrin, necrotic epithelial cells and polymorphonuclear leukocytes and other various types of microorganisms. Usually the microorganisms which are abundant is fusospirochetes, and clinically this shown appears as a pseudomembrane. Whereas coming to the connective tissue, this connective tissue is hyperemic, that is inflamed with numerous capillaries will be present and there will be dense infiltration of the polymorphonuclear cells. Whereas in the superficial connective tissue, there will be abundant number of neutrophils will be present. Whereas coming to the deeper connective tissue, there are other cells such as monocytes, plasma cells, there also will be seen. This acutely inflamed zone will be appeared as linear erythema beneath the pseudomembrane. Here we can clearly distinguish between epithelium and the connective tissue. So, relation of bacteria to the necrotizing ulcerative gingivitis. Here electron microscopic study has been conducted by Lyshgardin in 1965, who identified the 4 zones, and the zone 1 is bacterial zone, that is bacteria are abundant such as fusiform species and spirochetes will be present, especially the Treponema species. Zone 2 neutrophil rich zone, here neutrophils which will be abundant. Coming to the next zone, necrotic zone. Here there are necrotic epithelial cells, fibrin network, this will be seen. Whereas coming to the zone of spirochetal infiltration, where the spirochetes will be deeply infused into the tissues, and smears from these lesions showed bacteria, predominantly spirochetes and fusiform bacilli, and these are present along with vibrios and filaments. And coming to the diagnosis should be usually based on the clinical findings. So, bacterial smear is not definitive, but are useful for the differential diagnosis of the necrotizing ulcerative gingivitis. And differential diagnosis, it includes primary herpetic gingivostomatitis, desquamative gingivitis, agranulocytosis, cyclic neutropenia, and leukemia and ascorbic acid deficiency. And communicability, necrotizing ulcerative gingivitis often present in groups in epidemic pattern. Occurrence of ANUC is epidemic, but outbreak does not mean is contagious, and predisposing immunocompromised host response and presence of appropriate bacteria necessary for production of this disease. And coming to the management, the treatment of the necrotizing ulcerative gingivitis, there will be elevation of acute inflammation, which can be done by reduction of the microbial load and removal of the necrotic tissue, and treatment of the underlying causes, that is etiological factors, and elevation of generalized symptoms should be relieved, and correction of systemic conditions which predispose the host to this necrotizing ulcerative gingivitis. And the treatment should follow in sequence, and the treatment it should be divided into for ambulatory patient and non-ambulatory patient. Non-ambulatory patient is who will be present with severe systemic complications, whereas ambulatory patients present with mild systemic complications. And the first visit includes complete evaluation of the clinical signs and symptoms along with comprehensive medical history should be taken. And the goal of the main this therapy is to, that is first visit is to removal of the necrotic tissue and reduction of microbial load. On the day of the first visit, the treatment which includes removal of the pseudomembrane and non-attached surface debris, which should be gently swabbed with the moist cotton pellet, and the superficial, after removing the superficial membrane, area should be cleansed with warm water, and superficial calculus should be removed, preferably ultrasonic scalars, because it does not elicit any pain, and subgingival scaling and curettage are contraindicated at this time, because this subgingival scaling and curettage, because this condition will diffuse into the deeper tissues and may cause and further provocates a lesion. Unless an emergency procedure such as extraction or periodontal surgeries, these are postponed until the symptoms are relieved. And patients who has witnessed severe systemic complications, antibiotic regimen should be prescribed. Usually the antibiotics will be amoxicillin will be prescribed. In case of amoxicillin sensitive patients, either erythromycin or metronidazole should be given. In coming to one, patient should be instructed that patient should rinse with 3% hydrogen peroxide water and warm water for every 2 hours, and also patient should be told to use chlorhexidine mouthwash for twice a day. and patients should be suggested to take adequate rest, and patients who have systemic complications antibiotics should be given, and patients should be recalled after 1 or 2 days. In second visit, the patient condition will be improved and pain will not be there, but gingiva will be still erythematous, and there in case of in first visit we have done a scaling. Because of that there will be shrinkage of the gingiva leading to the exposure of the subgingival calycles, and in the second visit these areas where the calycles and debris are present should be again treated, and instructions will be given same as in the first visit. Coming to the third visit, usually it will be appointed after 5 days, and patient in this stage will be asymptomatic, and hydrogen peroxide rinses should be discontinued, but chlorhexidine rinses should be continued, and patient is instructed for plaque control procedures, and patient should be counseled on nutrition. And coming to the gingival changes with healing, usually after the removal of the pseudomembrane there will be inflamed gingiva will be exposed, which will be erythematous because of engorged capillaries in the connective tissue. And in the next stage, that is on the second visit, the bulk and redness of the gingival margins will be reduced, whereas in this picture there is in the first stage. This is the second appointment. Here the bulkness and redness of the gingiva has been reduced, and this is followed by restoration of the normal gingival contour and color, and the final stage, consistency, color, surface structure and contour will be restored, and portions of root exposed by disease will be covered by healthy gingiva. Whereas in this picture there are irregular contouring of the gingiva is seen, whereas at the end of the treatment gingival contour has been restored. And coming to the additional treatment considerations, contouring of the gingiva, that is gingivoplasty, can be done as an adjuvant procedure, because here the sometimes gingival contour will not be restored, which will not be aesthetically good appearance. So this can be corrected by an attempt to restore lost tissue through periodontal plastic procedures or through gingivoplasty, that is reshaping of the gingiva. And role of drugs. Here the large variety of drugs has been used for treatment of NUG, but topical drug therapy is alone as not an adjuvant measure. No drug when used alone can be considered complete treatment. So in case of persistent or recurrent cases, we have to focus on the reassessment of differential diagnosis to rule out NUG, and underlying systemic factors causing immunosuppression should be treated, and in case of inadequate local therapy it should be corrected, and inadequate compliance. And coming to the next condition called primary herpetic gingivostomatitis. It is an infection of the oral cavity caused by herpes simplex virus. This can be of two types, herpes simplex virus type 1, herpes simplex virus type 2. The one which causes the oral lesions is HSV1, that is herpes simplex virus type 1, and HSV2, that is herpes simplex virus type 2, usually causes genital lesions. It usually occurs or predominantly it can be seen in children less than 6 years of age, and it can also be reported in elderly patients, and usually the primary infection is asymptomatic. Whenever after patient is exposed to primary infection, this latent herpes simplex virus resides in the sensory nerves of trigeminal ganglia. Whenever it is triggered by certain factors such as either exposure to the trauma, fever or stress, or exposure to the sunlight. These are the triggering factors which provoke the latent virus which are in the trigeminal ganglion. Sometimes even the dental treatments also can act as a triggering factors. Usually the patients who will get treatment for dental, after 3 or 4 days this virus will be triggered and cause recurrent infection. And coming to the clinical features, oral signs, usually there will be diffuse erythematous gingiva. Because of erythematous, the gingiva will be hemorrhagic, and during the initial stages there will be presence of vesicles. Usually within 24 hours these vesicles rupture to form ulcers. These ulcers coalesce to form big ulcer. These ulcers are characterized by red. Here you can see this ulcer. These are characterized by red elevated halo-like margins and depressed yellow or greyish white central portions. Usually the course of the disease is 7 to 10 days. And coming to oral symptoms, this is accompanied by general soreness of the oral cavity which interferes with drinking, eating and chewing. Ruptured vesicles will be the focal site for pain. These are extremely sensitive to touch and food and action of coarse foods. This in infants, this disease is marked by irritability and refusal to take food. And coming to the extraoral signs and symptoms, which includes there will be cervical lymphadenitis, fever will be present and generalized malaise will be present. And coming to the histopathology, the common identification is Zang cells, which shows ballooning degeneration that consists of acantholysis, nuclear clearing and nuclear enlargement will be seen. These infected cells fuse to form multinucleated giant cells, whereas there will be discrete ulcerations that results from the rupture of the vesicles have central portion of acute inflammation. In coming to the diagnosis is usually established from patient's history and presence and clinical findings, that is extraoral signs and symptoms and intraoral signs and symptoms. Usually materials from biopsy can be obtained from the lesions for laboratory for confirmation test. This includes viral culture test and immunological tests. And differential diagnosis includes acute necrotizing ulcerative gingivitis, erythema multiforme and Stevens-Johnson syndrome, lichen planus and after stomatitis. In case of after stomatitis, I have mentioned earlier that central halo portion will not, which will be white will not be there, whereas in case of herpetic gingivostomatitis it will be present. Communicability, it is contagious and most adults have developed immunity to this virus during childhood because in most cases is subclinical. It is often not clinically significant and is destroyed by systemic diseases. Coming to the management, usually you have to assess. First, you have to assess the acute oral pain, that is mucosal status of the patient should be assessed. In case of mucosal status, whenever there is redness of the complete intraoral tissues or either only gingival tissues, we have to assess. In case of complete intraoral tissues, there will be discrete painful ulcers will be there, and there will be gingival ulcerations will be there. In case of mucosal or gingival ulcerations, we have to compare with localized or generalized. In case of localized, can be an office ulcer, whereas in case of generalized, that is complete either intraoral fully it is widely dispersed, we have to assess for either afebrile or febrile. In case of afebrile, there will be no diffuse erythematous involvement of gingiva or attached mucosa, whereas in case of febrile, there will be diffuse erythematous involvement of overall mucosa. And another time you have to access that most extensively by accompanying skin lesions are there. In case if it is have skin lesions, we can go for erythema multiforme. In case of no skin lesions, only perioral and intraoral lesions, we can conclude that primary herpetic gingivostomatitis. In case of primary gingivostomatitis, palliative therapy should be given. If the disease is identified before the 3 days of onset, acyclovir, that is antiviral drugs, can be prescribed. It is identified after 3 days of onset, only antiviral therapy alone will not be sufficient. We have to go with palliative care along with antiviral therapy. Palliative care includes both nutritional supplements. In case of pain, NSAIDs should be given to relieve this pain. And coming to the next condition called pericoronitis. The term pericoronitis itself denotes it peri around the tooth and coronitis, the coronal portion of the tooth. So it refers to the inflammation of the gingiva in relation to the crown of an incompletely erupted tooth. Usually it will be seen in most commonly is mandibular third molar area, and the risk factors for this are poor oral hygiene, previous history of pericoronitis and presence of partially erupted teeth and respiratory infections or tonsillitis. Here coronal portion of the tooth is covered by the gingiva. Here between the space between the tooth and gingival tissue, there will be accumulation of the plaque and food debris, which will cause inflammation to the gingiva. And another factor that causes inflammation of the gingiva is whenever there is an opposing teeth, usually causes injury to the pericoronal flap. Because of this, it will be an inflammation of the gingiva. And inflammatory fluid and cellular exudate increase the bulk of the flap, which will interfere with the complete closure of the jaws, that is trismus will be present. And coming to the clinical features, the most common site I have mentioned is mandibular third molar area. Then space between the crown and overlying gingival flap, which is an ideal area for accumulation of food debris and plaque, which provides an ecological niche, and there will be bacterial growth will be seen, even and which causes inflammation of the gingiva. Even in patients with no clinical signs or symptoms, this gingival flap is often chronically inflamed and infected. Here, this food impaction causes accumulation of the plaque, and which causes inflamed and swollen gingiva. And there is here the picture mentioned is a red swollen separated lesion that is tender with radiating pain to the ear, throat and floor of the mouth, and it is extremely uncomfortable as a result of pain. And there will be swelling in the region of angle of the jaw, and lymphadenitis and trismus are the common clinical findings. And coming to the complications, involvement can be localized in the form of pericoronal abscess. Whenever there is an inflamed gingiva, sometimes it will lead to the pericoronal abscess. So sometimes it may spread posteriorly into the oropharyngeal area or medially to the base of the tongue. Depending on the severity and extent, there will be involvement of other regions also. And systemic complications usually includes fever, leukocytosis and malaise. So, and in case of peritonsillar abscess formation also can be seen when it extends deeply into the cell, causes cellulitis and Liebig's angina. These are the consequences of the pericoronitis. In coming to the management, the initial treatment includes the space which is accumulated with the plaque and debris should be completely irrigated with warm water, and this swabbing this tissue with pericoronal flap with the instrument, and you have to clean that area. And it sometimes we have to decide based on that if the tooth is erupted and therapted, we can wait for a particular time. If the tooth is in the impacted or position of the tooth is changed, we have to go for extraction. In case of vertically erupted teeth, tissue that which is pericoronal flap can be surgically excised. While surgical excision, that is operculectomy, we have to concentrate both on the pericoronal area and distal area. If distal area is not treated properly, it will lead to the distally there will be pocket formation. To reduce the risk of bone loss around second molars or partially or completely impacted tall molars, it should be extracted early. If the decision is made to retain the tooth, the pericoronal flap, it should be, I have mentioned earlier that it has to be surgically excised. And patient education and appropriate instruction in long-term maintenance of periodontal health is an essential part of successful therapy. And coming to the differentiation between necrotizing ulcerative gingivitis and primary herpetic gingivostomatitis, whereas coming to the etiology, it is usually of necrotizing ulcerative gingivitis is usually spirochetes and fusiform bacilli, whereas in herpetic gingivostomatitis specific viral etiology will be them. It is in case of necrotization and it is a necrotizing condition. In case of herpetic, there will be erythema and vesicular eruptions. And characteristic includes here punched out gingival margin will be present, crater like margin will be present, which will be covered by pseudomembrane. Whereas in case of primary herpetic gingivostomatitis, vesicles will rupture to form an ulcer. In case of marginal gingiva will be affected and other oral tissues are affected. Whereas in case of herpetic gingivostomatitis, there will be diffuse involvement of the gingiva and it is uncommon in children, whereas this is more frequently occur in children and infants. There will be no definite duration in case of NUG, whereas here course is limited to 7 to 10 days. And there is no demonstrated immunity will be there in NUG, and case of acute episodes will be present. and it is not contagious and it is contagious. And coming to the differentiation between necrotizing ulcerative gingivitis, diphtheria and secondary stage of syphilis. Here the etiology I have mentioned is between host and bacteria, most probably spirochetes, whereas in diphtheria Corynebacterium diphtherium, in case of syphilis Treponema palladium. This affects marginal gingiva, rarely affects marginal gingiva and rarely affects the marginal gingiva. Here membrane removal is easy, whereas in case of diphtheria membrane removal is difficult. In case of syphilis membrane is not detachable, whereas in case of marginal gingiva will be affected. In diphtheria both throat and tonsils are affected. In case of syphilis any part of mouth can be affected. And serological findings will be normal in case of NUG. In case of secondary syphilis will be abnormal, and immunity is not conferred. Here immunity is conferred by an attack. Here in syphilis immunity is also not conferred. And here in case of NUG there will be doubtful contagious, whereas in diphtheria it is contagious, whereas in only direct contact. Whereas antibiotic therapy relieves pain in NUG, whereas in antibiotic therapy has minimal effect, and antibiotic therapy will have excellent results in syphilis. Whereas coming to the differentiation between necrotizing ulcerative gingivitis, desquamative gingivitis and chronic destructive periodontal disease. Whereas in case of fusive phyrohospital complex, here bacterial smears reveal numerous epithelial cells and few bacterial forms. Here bacterial smears will be variable. Where marginal gingiva is affected. In case of desquamation there will be diffuse involvement of marginal and attached gingiva. Here chronic periodontal disease there will be marginal gingiva affected. Here in case of NUG there will be an acute history, whereas in case of both desquamation and chronic periodontitis there will be a chronic history, whereas in case of NUG it is painful. In case of desquamation it will be may or may not be painful, whereas in chronic periodontitis painless only if uncomplicated by any other infection, secondary infection. Whereas here NUG pseudomembrane will be present, whereas in desquamation there will be desquamation of the gingival epithelium, whereas in periodontitis condition there will be no desquamations. Here the papillary and marginal necrotic lesions will be seen, that is crater and puncture lesions. Here papilla does not undergo necrosis in both the conditions. Here it affects adults and both genders. Here it affects both genders, mostly women. It generally found in adults, not in children. And characteristic fetid odor will be present in NUG, and desquamative gingivitis there will be no odor. In chronic periodontitis there will be some odor because of this accumulation of these etiological factors, that is plaque and calicles. Coming to the conclusion, here these acute gingival diseases are similar in that typically manifest with painful intraoral or perioral lesions, and these conditions are usually very painful and it is required immediate treatment to relieve this pain. And however each case requires careful assessment and accurate diagnosis and identification of risk factors. In many cases there are systemic risk factors and that increase susceptibility to acute gingival diseases. And these are my references. Thank you.